The Core 360 belt is the best aid to train the abdominal wall. The Core 360 is a patent-pending, first-of-its-kind training belt that helps you move, breathe, and perform better. We use the Core 360 belt with almost every patient at Winchester Spine and Sport. The biofeedback is second to none, and it's an amazing way to teach proper respiration and can be even used during higher-level movements in the gym. Teaching proper respiration is about as fun as a rash, but with the Core 360 belt, you take all the headaches away. Visit core360belt.com and use the code GESTALT for 10% off all belts, Ohmtrack sensors not included. Again, visit core360, core360belt.com and use the code GESTALT for 10% off. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. We got some more returning guests today, Brett. So we're excited to be sitting down with Erica Boland, Lindsay Mumma. So we just finished up the perinatal manual therapy or manual care course here at Winchester Spine and Sport. And so what an awesome weekend. This is the second time we've hosted y'all. And man, it was awesome. The only downside for Brett and I was that we thought we trusted them.
Yeah. The circle of trust has been broken.
We let them do their own thing for dinner on Friday, and then they kept our credit card. And today I was literally 30 seconds away from calling Chase to see that our credit card had been stolen because somebody was spending way less money than us at some random tattoo parlor in St.
Weldon Springs.
Yeah, Weldon Springs. And so I did the normal dad thing and pulled Erica into the corner and asked, did you guys go get tattoos with our credit card yesterday? And the answer was,
Yeah,
we
we did that.
That happened.
yeah, so that's the thing. So
It was fun.
It was a really good level troll.
yeah, I mean, it was honestly, the respect level is through the roof at this point.
The trust is gone.
Yeah,
the
well,
respect is higher.
Now, how long did you think it would take for us to notice?
At least a month. Yeah, I
I
have a reminder in my calendar to send you a check in a month because I didn't think that you would notice.
The funny thing is that our credit card has been compromised, like, I don't even know, 5 or 6 times in the last couple of months. So now I'm like a watchdog on that damn thing.
Oh, yeah.
And so today I was like, son of a...
I wish I would have had a picture of your face when you're like, did you get tattoos on my credit card last night? And my response was, yes. And your response was, actually.
Well, it was a tattoo and piercing spot. And so I thought I was going to go with the tattoo first rather than ask the piercing because...
just in
That's
case.
a smart play.
Yeah, just playing the odds.
Yeah.
So anyway, we're just glad to know that they got our faces tattooed on their body somewhere. That's what we're going to go with. It's actually kind of it's a good thing. So whatever, it's a compliment. We'll put it that way. So anyway, we'll move past the awkwardness of the weekend and let's get down to the nitty gritty. So we had a crazy mix of students this weekend.
Yeah.
So this is a perinatal manual care course. So this is literally like third trimester up to 6 weeks postpartum, right? That's kind of like the perinatal definition.
That's a textbook perinatal definition, but truly it's care for pregnancy and postpartum population.
Sure.
Manual care for
What was awesome, though, is we had actually more males than females here this weekend, which is this crazy. So it's so awesome because there's this stigma that you can't treat that population if you're a male. Or as Brett would say, if you have external plumbing. And so, Brett, you kind of got your start working with the pregnancy population.
Yeah, I'd spent 8 months of my life basically only working with pregnant patients at BJC here. So it's,
Really?
I think as far as like, a need, because they can't do pharmaceuticals or they're not supposed to. I mean, the chiropractors or physical therapists, I mean, they're set up like perfectly to be able to, deliver the treatment for this population. And usually the people that are doing pregnancy or postpartum, they're also doing pediatrics. So then like when I follow up with my postpartum females, then it's like a natural start point to be checking up with the baby. So
well, let's just outline it for those that maybe don't know about this course. It's relatively new. I mean, talk us through the weekend. What do we discuss and that kind of stuff?
Oh, you're deferring to me? Excellent. Okay. I have no problem talking. So we start off with definition of core and pelvic floor, because that is the area of the body that changes, like in literal juxtaposition and also in its function and in its capacity and in its need and in its loading through pregnancy, and then rapidly changes in the postpartum time period. And so we start off with core and pelvic floor stuff, then we'll get into the lumbopelvis, and that's kind of the area of the body that is known for causing the most discomfort during pregnancy. I always say that it's like a rite of passage to have low back pain when you're pregnant, but really it's not necessary. But pregnancy tends to highlight a lot of the things that were issues beforehand. And so we go into what typical pregnancy expectations would be and how we can address those things with our patients with a variety of manual therapies and tools that you may already have in your tool belt, but you're not necessarily applying to the pregnant patient. We also get into thoracic spine issues, and then we do a whole section on cranial work and incorporating that into a functional orofacial system. And then and the whole weekend is kind of incorporating more rehabilitative exercises. We use the functional progression, which Erica created based on DNS principles, and demonstrating how breaking down these movement patterns with a body that is rapidly changing is incredibly powerful, because we just bring back to the basics. And then the cool thing about working with prenatal and postpartum patients is the things that you learn for working with that population, you can apply to any other population. But the reverse of that is not true. Like, you can't do things that you would do with anybody necessarily with a pregnant patient or an early postpartum patient, but you can do any of the things that you would do during pregnancy or postpartum with other patients. So it's really applicable outside of what you learn in the weekend.
And now, Erica, pregnant females are fragile little butterflies, right? And so we shouldn't adjust them. Manual therapies kind of gets thrown out the door.
They shouldn't be working out.
Right.
Yeah.
You shouldn't be doing all those things.
All that. So in the seminar, over the course of the weekend, we do talk about that and kind of flipping that on its head, and the benefits of movement alone in pregnancy are exponential into postpartum healing. So obviously, training and preparing for the rest of pregnancy, for birth, the marathon that labor can be, but when that's addressed prenatally, then your patient is set up for better healing postpartum. And that's the part that lasts forever. And I think another thing too that we talk about over the weekend is the stigma of care plans and chiropractic. And we get into, this is a population that is really truly needs a functional wellness-based model because, like Mumma said, of the rapid changes. And even the American College of Obstetrics and Gynecology is recommending more frequent and improved quality of care postpartum, but it's not happening. Mm-hmm. And we are the musculoskeletal experts. So one of the guys that was at the seminar this weekend said, like, this totally changed my perception on working with this population, because really, truly, it comes down to just knowing the way that the body moves and applying that to this population. So,
and this is a lot of the concepts that we covered in both of your first episodes. So if you haven't checked out those, Lindsay's is kind of hidden. You're one of our first ones, so it's down there a little bit. You have to scroll a little bit, or you can just search it. Erica's a little bit more recent, but we kind of went through a little bit more of the specifics. But Brett and I thought today, since you're both here, I think one of the most misunderstood things in the human body, and especially rehabilitation, is the pelvic floor. So we get into it at DNS. We talk about the top-down approach with the diaphragm and pelvic floor, but maybe let's just kind of start with what makes this area, I guess, so prone to needing rehab or needing therapy afterwards. Doesn't it just kind of go back to where it was after pregnancy?
Or I think a better jump-off point might be, you hear like different experts in the world say the pelvic floor has too much tension, they need to be able to relax more. And then you have like another group of people that are saying, the pelvic floor is inhibited.
Okay, so I think a good jump off point would be, what is the status of the dysfunctional pelvic floor? Do we think that it has become neurologically inhibited, we need to train it? Or you have another group of people that are saying there's too much tension in it, we need to relax it. Is it a little bit of both? What are your guys' thoughts on like the current thought of what we're needing to do with pelvic floor training?
Yeah. Well, for full activation, really truly, the muscle group needs to be able to fully relax, like for full function. So especially today when most people in society are already carrying around so much tension, what I'm finding is there is a lot of tension in the pelvic floor. And so it's awesome now in midwifery school to be able to see when that translates from chiropractic practice to labor and delivery and then into postpartum. And like one of you said, the top-down approach of working with the diaphragm, that's where I start with every single one of my patients. And the goal is communication between diaphragm and pelvic floor, and just the patient's ability to actually connect with their pelvic floor at all, because likely they're holding tension there without knowing it. And, when did that start? Well, I think that starts from a very young age, whether it's societal norms or pressures or stigma or whatever. We just really in general become disconnected from that area of our body. And yeah, so that's where I see the most dysfunction occurs in tension.
Perfect. So then how often would you be using like an internal physical therapist for internal work on the pelvic floor?
So we get into this in the course too, and there's different camps with that as well. Not everybody's open to that, and I think it's important for chiropractors to realize like you can do so much to help treat the pelvic floor externally. If people are open to having internal pelvic floor work, I do think that around 6 weeks postpartum is a really great time to do that, especially to see exactly how the pelvic floor is functioning, especially if anybody is interested in or has been recommended to do any sort of Kegels, which is like single muscle group activation of the pelvic floor. That really needs to be done with a professional. So I have the conversation with my patients that I recommend seeing a pelvic floor PT for internal work around 6 weeks postpartum.
That's everybody, or?
It is. There's some patients that I know are definitely not open to that, so I'll still share the information because it's my job to be fully informative in that way. But yeah,
right. Okay, and then males have a pelvic floor too.
What?
So,
They
do.
Yeah, they do. They have less holes in their pelvic floor. Right. I mean, legitimately, that when you think about that actually changes the pressurization that happens within the core canister. Like, it does matter that you have less holes in your pelvic floor. But this is the cool thing about working with a functional core is it doesn't matter who your patient is. You can help improve their stabilization strategies by doing that.
So then I think we all are in agreement we don't specifically use a Kegel, but do you ever give like internal female cues to the patient to get some activation there when we're exercising, or not necessarily?
I'd give internal cues. I guess in midwifery I'm a little more like actually internal than certainly I have been as a chiropractor. But I'll teach patients how to do a internal release just with using their thumb, or if they're not even comfortable using their own thumb or hand, then like sending them information on a pelvic wand that they can use to find trigger points within the pelvic floor, and then same as any other trigger point in the body, just holding tension there on their own. And ideally we've already worked on breathing mechanics, so then they use those breathing mechanics to help release those trigger points, and then it just brings that proprioception and awareness further into the pelvic floor.
But you would never say like lift your vagina up or cut off your urination stream. Like, you don't use any of those cues at this point during exercise therapy?
I don't.
I do not.
Okay. Mm-mm. Perfect.
There's a kind of cue that sometimes I learned this from Martina in the DNS Women's Health course of like a sucking motion. So like having the patient stick their finger in their mouth in order to create suction so that they feel what their pelvic floor naturally does when it lifts. That is really good for just kind of creating an awareness in the pelvic floor. And that's where, that's what Erica was saying. So much of this stuff is really an awareness issue. So many people are so disconnected from what's happening within their pelvis in general, and they're half-assing their ability to breathe with their diaphragm, which is kind of where, taking that top-down approach is really important. And so getting the awareness of this is what your pelvic floor does if you create suction.
Right.
That's kind of helpful. And that's sort of the closest thing to that I do in practice.
If 20% of the postpartum female population who has a vaginal birth has leakage with coughing, sneezing, laughing, and we put them in the right protocol, of that 20%, what percent of them would have 100% resolution in that problem, would you say?
I really truly that believes in consistency, and that's going to change over time. So I would say complete resolution, that I would be throwing out a number, but I would say you could have complete resolution with consistency in probably 70 to 80% of patients is what I'm seeing in practice. There's obviously occasionally other contributing factors, or maybe it was there before, but different events will happen, mental, emotional, and physical events will happen in life, and your pelvic floor is affected by that. So whether it's illness or honestly death in the family or something like that will affect the connection to that area. So then you'll see this re-exacerbation of symptoms, which can feel a little bit like hopeless when, okay, I've done all this work, I have all these tools, and now it's bad again, or it's getting worse or whatever. And that's just communication from your body that, hey, we need to recalibrate again and like focus back in here and use the tools you have to continue to improve. So the biggest difference there is consistency, is what I see.
And then how long of a program, I know it all depends, but like how long of a program do you think it would take for the people that are listening here? Like if you're going to try to change that, like how much time are we needing on average to be able to make that change?
Are you saying like per day or per week?
No,
treatment
like
plan.
a treatment plan.
I see.
This is one of the things that Erica actually goes over in
the care plan. Yeah, so I move through the functional progression ideally in 4 to 6 visits. That depends on the awareness with their body. So that usually takes about 3 weeks. And then we're getting more into like foundations of strength, because we know from evidence and research that strength training really has great long-term pelvic floor outcomes. So that programming alone can be anywhere from 6 weeks to 3 months, depending. But the goal for me, and I would say, Mumma, similar for you, is always to keep them moving in a way that they like to move. So as long as we can add function to whatever their movement practice is and keep them consistent with that and keep them enjoying that and moving well within it, then we see better pelvic floor and core outcomes long term.
Right.
So it's kind of like a potentially 3 to 6 month on-ramp into their movement practice.
Right.
What about then, that's kind of like this end of the spectrum, what about the other end, prolapse? So even during pregnancy, after pregnancy, stuff like that, I mean, is that still in our realm? Are you still talking with them? What's that look like? I mean, talk us through maybe the extreme case of that, or does it change at all?
I mean, ideally, yeah, I mean, that, I guess when Brett asked that question, for me, that includes any pelvic floor dysfunction.
Sure.
Yeah, I would agree. And, research, which is behind what we're able to do in clinical practice, because that's what we're studying, is what's already being done in clinical practice. So just a reminder that if you only practice what is available in evidence, then you're behind. But research shows us that, with good rehabilitative care, we can expect, like with very solid consistency, that you can decrease a prolapse by 1 grade. So like if you have a grade 2 prolapse, then you can expect that with just a course of PT or manual therapy and chiropractic care, you can expect to see that would decrease by 1 grade. So that's like expected within the literature. So that tells me that's base level of what we can do. And some people will say, well, that's all that we can do because that's what the research says. Well, I have seen that patients have had better improvements as they continue to revisit that. And so one of the hardest things with recovery of pelvic floor stuff is, after birth, you have such a lack of stabilization that you really shouldn't be able to even walk around. But you cognitively know how to walk around. So you're able to get up and move around, and then you pick up your kid and you're doing all of these things that are adding load to a completely destabilized system. And it's really hard sometimes to rein that in and have patients understand, we really kind of need to stay in a functional place for a while before we step into that adaptive gap. But if we do that, if we really do get a solid foundation down, then when you get into that adaptive gap, it will feel really good to do so. It will feel really good to build strength on top of function instead of build strength on top of compensation. And so I think one of the challenges with working with pelvic floor dysfunction is that because people for such a long time have just assumed that it's like a thing, you know, the rite of passage of pregnancy is that you have low back pain, and the rite of passage of postpartum life is that you pee your pants and you just cross your legs whenever you sneeze or cough. And so for such a long time, we've kind of kept that hidden. I mean, I intentionally ask 3 separate times with a new patient if they have any symptoms of pelvic floor dysfunction. And so, and sometimes on the first question they say no, on the second question they say no, but like with a caveat. And then on the third question, where I actually am asking specifically these specific symptoms, do they kind of elaborate a little bit more? And so people are sort of hiding this information, they're holding it in, and then they're literally holding it in and creating more tension and kind of feeding into that dysfunction. And so I think one of the challenges is it takes a little bit longer sometimes because the patient is wanting to do too much too soon.
What are some of your favorite questions to kind of tease it out? Maybe 2 or 3.
Oh, to ask patients if they are experiencing. So, the OPQ or ST type of questions of what are your red flags? Do you have any stress? Or do you have any incontinence? And then in parentheses, I've added to that question, including stress incontinence. And I'm so surprised at the number of patients who don't know what stress incontinence is. Like, I think that that's kind of something that's in the vernacular that people would just be aware of. But so many patients are like, I don't know what that is. So do you pee when you cough, laugh, sneeze, jump, run?
I think that's the key way to, especially as a male, the males are listening to that. Because if I were to ask the patient, do you have pelvic floor dysfunction? Their answer will be no.
Right.
But if I frame the question right, then you'll get the answer that you're looking for.
So technically I actually do have 4 ways that I ask that question, because there is one little box where some patients are literally just coming in because they know that we do work with pelvic floor dysfunction. And so is this why you're coming in, checkbox? So they may say that. And then in those OPQ RST questions that there is that question. And then there is a checkbox of what symptoms of pelvic floor dysfunction can be, and that, we go over that in the course. And then I ask them out loud. So it's not just on the form, and I intentionally go through the form questions and ask audibly for you to expand on things that you have said yes to. Right. But on that question specifically, even if you've said no, I will ask clarifying questions. Do you pee your pants when you cough, laugh, jump, sneeze, or run? And sometimes I will add in, what if you go to a trampoline park? Because that's an extra layer of stress. We're like, oh, no. But the reason why is because they're not doing the things that they know will cause them to have a symptom show up.
Right.
So could you go to a trampoline park today without wearing a pad? That's a solid question.
And I even further, do you leak any amounts of urine instead of pee your pants or have incontinence or whatever? Because sometimes people think complete loss of urine function or honestly bowel function as well is where the issue is, but really it's even just a small amount of leaking they don't have to deal with.
But that's just a rite of passage with CrossFit, right? That's the new Instagram phase is everybody just completely peeing their it's insane. But anyway, that's for another day. Perfect. Okay. And then so then what about if you both had take respiration out? We understand that just training respiration is the starting point for everything. Give us maybe your 1 or 2 favorite positions or exercises to train the pelvic floor in.
I would say functional progression 2 and FP4, specifically with FP4 because so in that position you're in quadruped and then bringing pelvic floor up above diaphragm, like lifting glutes above diaphragm. And then when they breathe, that's an eccentric load on diaphragm. So again, diaphragm and pelvic floor are communicating. So even if I don't start with diaphragm and they're in that position, they have to breathe. So that's just naturally going to happen. It's going to increase that awareness. And then FP2 is a sideline position and it really helps connect the slings of the body and naturally integrate the pelvic floor into hip rotation and shoulder movement. And so that sort of function can occur without them having full connection or awareness of their pelvic floor yet. Is it going to improve it if I start with diaphragmatic work? Absolutely it will, but I think the biggest takeaway in all of it is when you improve biomechanics, you will, whether it's at the shoulder or at the hip or at the ankle or foot, you will improve the pelvic floor function.
Complete agreement. I use
can't
functional
choose those two.
progression in
Different
my
ones, those
office.
are out.
I will add to that the 90-90 shin box position into the DNS half kneeling, kind of that a tall kneeling tripod sort of position. Those are fantastic. So in the half kneeling position, that's really the first time that the foot is being loaded for weight bearing. And so that is really helping to integrate the foot function with the pelvic floor. So, Erica was just saying, like, if you're addressing the biomechanics in the foot, you are absolutely addressing biomechanics of the pelvic floor, and you can improve that. And so that one I really find is incredible for getting glute stabilization to really be something that the patient can feel. And it's also a very humbling exercise. Like, a lot of people cannot do those two exercises well, and they try them and they're like, holy crap, like that was freaking tough. And so it's nice to be able to demonstrate. This looks like a very, very, very simple exercise, but there's still so much work that we have to do in order to get you to full recovery. And so those are two of my favorites. And I usually kind of group them together, where I do the 90-90 shin box into the half kneeling and back down again.
I mean, you look at the population in general, and just the glute activation is so lacking. So to be able to take that position that she uses and give them a better awareness of their glutes, even in just seated, even then, it's just so impactful, powerful on the pelvic floor.
So neither one of you said squat, which, a lot of people, that's like, their go-to. So is there a reason why, or just...
The only reason why I don't typically start with squat is because there are so many facets of necessary adequate biomechanics that need to be in place in order for you to do a good squat. Like, if your ankle mortise dorsiflexion sucks, then your squat's going to suck, and now it's not helping your pelvic floor, because now we're training compensation. And if you think about it from, like, if you were to do like a purist sort of approach to DNS, like, you have to do these things first before you can get there. Squat is at sort of the end of the ability to create new human movement in that first year of life. And so squat is, you got to earn a squat. And yes, the squat is incredible for training the pelvic floor, but you have to earn getting to a squat.
And that's more like in rehabilitation too, right? So when we're thinking about the immediate postpartum person, they have gone through all of those sequences. So sometimes having a little bit of an axial load, or like even if it's just carrying the baby, is what helps them find their core again and what helps them activate again. And so there is an extent where the functional progression really needs to just be supplemental to the movement, and they need to be bearing weight. Like, even just lightweight, 10 pounds, 20 pounds, 50 pounds, whatever, that will help them, especially once they've gone through some of these, like, reintegration of the biomechanics. It will help them really feel what it means to activate their core in a better way. So I would say squat would be my go-to right after that. And honestly, it would be one of the places I would start during pregnancy, because that's so important to be able to access during labor.
It's an incredible option for laboring and birthing.
And like the number of people that most of the people watching this podcast honestly probably work with a pretty active population. You've got to remember that not everybody is as body aware as the active population is. So we've got patients that aren't even comfortable due to fear of getting into a squat because they haven't done it in so long. And these are like women in their 20s. So
how often after birth, we have relaxin and other hormones that are free floating in the woman's system to allow the childbirth to occur. At what point afterwards is that no longer an issue, and they start to be able to stiffen their joints back up again and
stabilize better? So it actually is changed or compromised through the end of breastfeeding because of estrogen levels. So when I talk to my patients about that, it's like, you will continue to see improvement after you are done nursing your last child. That isn't a reason to stop nursing, but also it's hopeful that there's still improvement to be made, even some people like years later, right? But yeah, the hormonal shift remains for that long.
What are the barriers that you guys see with in your difficult cases? Like, what are the things that the patients are having a hard time like grasping as far as like the pelvic floor training?
I think one of the hardest things is having a patient change their posture. And so many people are just so happy to sit in this horrible slouched position. And what that does to the pelvic floor is so hard to combat with, twice a day rehab exercises.
Right.
And so I tell patients all the time that, my follow-up visits are 15 minutes. And so I tell them, you have 23 hours and 45 minutes of the day that you are on your own. Mm-hmm. So I can do really great care here and I am happy to help you. But if what you're doing for the majority of the rest of the day is combating what we've done in the office, then it's going to take you a lot longer to get better and to reach the goals that you have and to reach the potential of what your body is capable of. So I think it's a really hard thing to change posture, and especially in the postpartum time period when you have this kind of empty space of where the baby used to live in your body, and then you have breast changes and you have postural requirements of holding your baby and you're nursing and looking at the baby, and so much of that is this forward rounded kyphotic posture that significantly impacts your ability to use your core appropriately, which includes your pelvic floor. And so I think that's one of the hardest things, is just the take-home aspect of your repetitive things that you're doing all day, every day.
Yeah.
And honestly, I think it boils down to the mental component of it. Consistency is key, and people want a quick fix.
Yeah.
And there's a lot of responsibility in taking ownership for your own health, and movement included. So I think long term, that's the biggest challenge, is realizing like this isn't a box to be checked. This is something to continuously practice across your lifetime. And it has to mean something to them for them to really grasp onto that and really make the change. So
I think too, it's sometimes they're way more unstable after the childbirth, just because up until that point, basically the baby is giving the spine support from the front.
Mm-hmm. Yeah. Mm-hmm.
So they, most people don't, consider that. There used to be a picture of movement stability and low back pain, Fleming's book, where they had an x-ray of a pregnant lady, and the fetus was basically pushing up against the lumbar spine. So although like globally they look like they're in an anterior pelvic tilt, which they are, but their spine is actually in a little bit of hypolordosis because of the pressure of the baby against the lumbar spine. So, when we look at low back pain, SI joint dysfunction is kind of grossly overstated. Mm-hmm. But in the pregnancy population, do you think it's understated? How much are you seeing like actual SI joint dysfunction in your pregnant or postpartum females?
I would say almost probably 50-50 of something, like the driver of dysfunction is coming from the TL junction or the SI joints. That's probably not true. It's probably higher in the TL junction than it is in the SI joints. I would say that the SI joints are more dysfunctional in pregnancy, and I think that's simply because of the needs that are required of the pelvis in pregnancy. But what you were saying about the baby kind of creating pressure, so like the core is destabilizing during pregnancy, but you have this adorable space occupying lesion that is actually taking up space and increasing the intra-abdominal pressure that you have present, and it kind of lends itself to a little bit more stable feeling. And then in the postpartum time period, I do see more SI joint laxity than during the prenatal population. What would you say?
I would say the majority of what I see related to SI is instability.
Mm-hmm. Right. Yeah. Mm-hmm.
Really,
which that would be what I would expect.
Yeah. A pregnancy or a postpartum, either way, I see much more instability in the SI joint than I do and
even like Laslet's cluster of tests for the SI joint. And he's even on record as saying, it's a really good test on the postpartum females.
Yep.
But what's frustrating for a bunch of chiropractors is doing his cluster of tests doesn't necessarily tell you whether you should manipulate it or not. It's just telling you whether or not that's the pain generator.
Yep.
Yeah.
What about, when we look at a bird's eye view of the pelvis, obviously we have two SI joints, and in the front we have the pubic symphysis, which in the everyday population, I'm not going to say never because we see it a little bit, but rarely do we see dysfunction in the pubic symphysis, but we do see it in the pregnant postpartum group of people. Is there anything you guys do specifically for pubic symphysis issues?
Stabilize the glutes.
Yes, so glutes, and then
I mean, if you think about it from just from an anatomical position, and this is one of the things that we cover in the class, but the rectus abdominis is attaching into the top of the pubic symphysis, and the adductors are attaching into the bottom of the pubic symphysis, and so the
pelvic
adductors
diaphragm attaches to like the bottom and inside of the pubic symphysis. Like there's just so much when there's that added weight from baby and like
the
increased blood flow.
Yeah.
Then something is going to have to compensate if there is not stability and like quality biomechanics and function there in the first place. And then that's where, like Mumma said earlier, where pregnancy is this time where you just see any dysfunction that was there before just kind of be a little
just
more
shine
prominent.
a flashlight on it.
Yeah.
But the treatment is to reintegrate the muscles around that area,
absolutely.
because in chiropractic lore from 100 years ago, I mean, there's all kinds of crazy, and even in the osteopathic profession, there's up slips, down slips that everyone's talked about, and we've kind of like done away with that. But so the answer was to reintegrate the muscles better around that area, basically.
What about any tips for like quick strikes in pain or anything you've seen, like people that have pregnant females that have lightning crotch, right? Is another plant thing for it. Anything in that first visit or that they can do at home that's tried and true for a quick strike in pain?
I use the 90-90 to kneel or kneel to 90-90 because sometimes that even just that position of the hips is a little more stress on the pubic symphysis they can handle if they're acute. So just getting them into a kneeling position and having them move over their hip, like move back through their hip using their glute and then coming back up and just really wake those glutes back up. And sometimes you have to peel it way back. We just talked about this today. One of the things that I like to do if they can't even really activate glutes in that position is just simply start with a basic glute bridge. And just, again, that's more proprioception based. And what I do is put a yoga block between the knees and a resistance band around the knees. And I have them feed into the resistance band just enough that the yoga block doesn't fall because we want collaboration from the external and internal rotators, but we need it, if there's decreased glute med activation, that's a way for them to figure out what that should feel like within their movement. And then we put them back into that position and then they can do it better because they're a little bit more aware of it. But asking questions too about what position are they sleeping in, what position are they sitting in, what are their day-to-day activities, and finding the underlying issue there.
And if you saw 100 patients in this population that have low back pain, how often would you be putting a belt on them for stabilization?
Probably twice.
That
so
sounds
2
about
out of
right.
100, yeah.
I mean, I don't have any belts in my office.
You got
and
that
I'm
question today.
I
though.
did, yeah. We were talking about that today. I don't lack sympathy for the person who is in so much discomfort because they have so much instability, but my preference is to use as few external crutches as possible. So,
right.
I don't
but
carry
the
them in my
does
office to
exist
sell
for
them.
you.
Yes.
Because at the end of the day, it's like, okay, if you can't even function without that, then we need to use that as a crutch for a little bit. But let's teach you how to better integrate the system while you're doing that.
Right.
Because those belts are also a pain in the ass to put on and off as you're moving, and as belly expands, it's not like it's comfortable to wear. Most people actually don't want to rely on that anyway in the first place. But if the pain is so severe that they're having a hard time functioning, then maybe the reason I say 2 out of 100 is because when someone comes in to see me pregnant, we automatically start into diaphragmatic work and functional progression. So then ideally we're not getting to that point.
Right.
Yeah.
Right.
That's more
But I mean, we
someone
have
that's
those
coming
patients
in.
who come in at 36 and they're like, "Oh, my baby's breech. I heard that you can do this,"
Yes.
and it's nobody likes to be in that situation, parent included. Nobody really wants to be in that situation, but like we do see those kind of like super late term cases where they're coming in and it's like, well, I would have loved to introduce core stabilization strategies to you before you even got pregnant, but here's where we are right now, and I see that you're wearing an SI belt and that you're in extreme discomfort, et cetera, and you just kind of got to deal with what shows up to your office that day.
Right. The evidence-based group recently, like in the last couple of years, has really questioned whether or not chiropractors, physical therapists can actually turn babies with their techniques. So their argument would be, if it did happen, it was just going to happen anyways, and there was no what's your guys' answer to that when you hear things like that?
So my stance on that has changed a little bit since being in midwifery school, honestly. So we go over you have like your anatomical normal in the textbook, right? And we're talking about ideal baby position, which is vertex, meaning head down with the chin tucked and the tip of the crown pointing against the cervix, and that's what helps dilate and open. Or if baby's in a breech position, butt first, etc. The reality of it is there's so much variation in the pelvic outlet, woman to woman, that the best position for that baby is whatever the best position is for baby to come through the pelvis that it's in. So all that we can do as providers is increase stability, mobility where it needs it, like improving those biomechanics, and then baby can find the best position for itself, because there is no perfect position. And I mean, breech birth is a lost art because they don't teach it in schools anymore, but it's not like it's a negative thing.
Right, like it used to be.
Yeah.
But so not to hold your feet to the fire,
No,
but
that's
do you
fine.
think that people can turn the baby? Like, do you think that's maybe you don't want to,
Turning
but
the baby is practicing obstetrics without a license as a chiropractor or a provider. But do I think that you can open up, like if there's a ton of restriction on the right side of the body and you're doing soft tissue work and you're doing, stabilizing, where you're doing all of the musculoskeletal care? Absolutely, I think the baby can find a better position.
right?
And
Just a piece of room at that point, right?
Yeah.
Room.
It becomes like real estate.
Yes.
Yeah.
Yes.
There's not as much real estate over here. I'm not going to get into this position. Yeah.
Right. So I don't think that chiropractors or PTs necessarily move babies. What I think that they do is create a more optimal environment.
Right. And then, like in traditional Chinese acupuncture, just as an example, there's like certain points or meridians that can initiate labor. What do you guys think about that?
The acupuncturist in my office sees a lot of our prenatal patients, and I mean, they have really great results. And that's actually one of the things that has been studied with IVF specifically is acupuncture and traditional Chinese medicine. And they actually have pretty decent evidence of how supportive it is. But I've had patients who came in for acupuncture and they had the points to supposedly induce labor and still ended up having that. Not at the end of pregnancy, a baby is going to come. So we kind of find ourselves in that situation where was it going to happen anyway, or you get too far and now the provider is wanting to induce anyway, and but I think,
or do you think it even is it just that you're putting needles in the musculoskeletal system, or that like it's actually this exact point that needs to be hit to get the desired effect?
I think that I am not a licensed acupuncturist. I do dry needling, and that is intentionally for the neuromusculoskeletal benefits.
Right.
And acupuncture is intentionally energetic work.
Right.
So that is a whole new ball game, right? So energetically, if you put a needle into the outside of the pinky toe, like what sort of realms are you tapping into right now? I don't know.
And don't underestimate the power of the mind.
Exactly.
Oh, for sure.
Exactly.
Yeah. Power of suggestion is huge. And you might as well play into it.
Yeah.
Yes,
And,
absolutely. There's
part of
nothing
that
wrong with that.
is preventative as well, right? So we get what I will tell you is that chiropractors are really, really great palpators. So as far as feeling baby's position, if you notice that baby is in maybe not a vertex position, not that you're legally supposed to diagnose position, etc., whatever. But I start noticing those sorts of things at around 32 or 34 weeks in comparison to 36 or 38 weeks, because there's more space to create change. So then I can give them inversions and different things to let's help this out, and again, not specifically for breech presentation, not because breech is bad, but I know what they're up against in our area if they're birthing in the hospital and they want a breech and they want a vaginal birth. So there's things like spinning babies and like I said, inversions and soft tissue release and all of this that we can use again to create the most optimal environment for baby. And the more aware you are at about that 32 to 34 week mark, you can make a little more change than when baby's grown bigger and runs out of real estate, really.
And I think too, kind of to that point, and sort of to touch back on the acupuncture thing, you know, if a patient decides I'm going to go to an acupuncture appointment and I'm going to sit or lie down for an hour and take care of myself, like, you know, it can be a stressful situation where they're like, oh, I'm supposed to have my baby and I haven't had my baby yet, and I'm super, you know, kind of freaking out about it, and they get in this heightened stress awareness sort of situation, and so they take that time to down regulate. And so I tend to give patients the Miles circuit to help them, because it's 3 positions and they're 30 minutes each. So like if you're taking time to do 90 minutes worth of something every day where you're not doing anything else, like the down regulation that comes with that, whether it's the positions are magic or not, but you're taking 90 friggin' minutes of your day to commit to not doing anything else. I think that's really, really powerful.
Yeah. What do you think about, like, a question we get often is, you know, because we have some holistic birthing centers. So, but then like the typical patient who's grown up in Western medicine, you know, they'll say things like, well, you know, what if we needed a NICU or something like that? Like, what do you guys, I mean, how do you have these conversations with your patients? Like, what are some of the things that...
Can I answer that first as the not midwife?
Sure.
So what I say is how impactful it was for me to see midwives be able to determine what looks safe to them and what doesn't. And so they're so much faster at saying, this is not in my scope, and this is something that I need to refer out, and this is not a birth that I'm comfortable with accepting into the birth center or as a home birth, and passing those on to a different provider, because they are so well trained in normal physiological birth,
right,
that they can recognize any sort of difference from that physiological birth quickly. So whether it's pathological or just a different variation, they are so quick at recognizing that and ready and willing to pass that on. And that's where, you know, when you get into some of the legalities of midwifery, like CPMs in North Carolina cannot legally practice home birth midwifery. And so if they want to refer out, well, then they kind of have to like cut ties with that patient, as opposed to continuity of care and transferring them. So, you know, it gets a little gray there, but with, you know, a legal home birth midwife situation or a birth center situation, those types of scenarios, they're so well trained in physiologic birth that they recognize yellow flags, whereas what I see within kind of like the traditional obstetric model of care, they recognize red flags, and they're really great at managing those red flags, but they don't really have to pay attention to the yellow flags because they're so ready for the red flags. Midwives are like, oh, that's that green flag is turning chartreuse, you know, like they're starting to recognize things so much earlier in the process that they're ready to pass this
They're
on.
better at triaging. Sounds like they're,
yes.
Okay.
That's what I would say as the not midwife.
80% of the time birth is normal and physiological, and 10 to 20% of the time it needs some sort of assistance. Even less than that is it an emergency. And it would be great if we could always anticipate what would potentially be risk. But now, having been involved in the opposite side of that, when you have someone that's very low risk, no indicators of any concerns, and then you end up in an emergent situation, if you are choosing to have a community birth, whether it be home birth or birth center, I am an advocate for choosing a midwife that is trained in neonatal resuscitation. I'm talking to my patients about the fact that they are prepared for an emergency if you choose the right midwife.
Right.
Not all midwives are good at triaging the same way that not all chiropractors are good at referring when it's out of their realm. So, you know, the proactive side of that, like Mumma's talking about, where they're able to watch over prenatally to see if any yellow or red flags show up, that's like the easy part of the job. The hard part is knowing what to do when there's something that happens postpartum, and that, or like during that third stage, and especially early fourth stage of birth, and being prepared for that and taking that seriously as a provider.
Is there a provider network that like people like can go on and like find, you know, like these people that are trained the way that you are, that would be a good, you know, sourced referrals?
No, there's not.
You just basically
a lot of it is word of mouth, and a lot of that is state to state, because some states it's legal and some states it's not. And as we know, the legality of things doesn't change the fact that it's happening. It just changes how and who it happens with. So asking questions more like, are you trained in neonatal resuscitation? You know, what sorts of things, what's your transfer policy? If there is an emergency, what does that look like? It's always a good idea to be a maximum of 30 minutes away from any hospital anyway. So it's more about asking those questions. Those aren't conversations that are fun and that people want to have, because we never want to think that an emergency is going to happen. But when you're prepared for it and the whole team is on board, I mean, especially the parents, with what happens in case of emergency, then that's where you're really truly safer in birth.
Well, I mean, that's no different than any kind of doctor. The best doctors in the world, they're great critical thinkers. They make great decisions in a big moment.
Yeah.
Sometimes it's hard to know whether or not that person is good at that or not just by meeting them, you know.
Yeah. And ask, I mean, if you want to know who the good midwives are, the good chiropractors, the good Ps, et cetera, in the area, ask the doulas in the area. They know the good, the bad, and the ugly.
Yeah, right.
It's true, because they're in it for the beginning, basically.
Yeah.
Right. I mean, they're usually so awesome. Well, what a good conversation, man! Oh man, that was great. I feel like we kind of cleared some things up, and I'd be renounced if I didn't say our next course coming up for you guys.
Yes.
So we're going to be in Annapolis, Maryland. So October 8th and 9th. We're excited to take you guys on the road a little bit, you know?
I'm excited.
So, and then we'll be back here in Troy basically a year from now. So for the same course, yep.
Even despite the tattoos,
Despite the
having us
tattoos.
back.
Well, so they're looking for some good tattoo artists in Annapolis. So if anybody's got anybody,
they'll more than likely have our damn credit card again. What's funny is they actually
checking those charges.
They requested one for themselves, and so now I know what's actually going to happen.
Yeah.
This is literally like we're parents here, and these are our children.
Please, Dad. Please, Dad.
Can I have some more money, please?
So, despite the tattoos, we still love them. But they're
Thanks,
too good of teachers to not allow a couple tattoos every once in a while. You know, you just gotta let a little bit of stuff slide.
right? Yeah. Exactly.
But anyway, thank you both for being here. Number one, thank you for educating us. Thank you for educating our people. And this is just a topic that I know Brett and I are passionate about because it's underserved. Information is kind of mixed, especially in the chiropractic world, and so for you guys to bring this all together into one 12-hour weekend seminar is pretty amazing. I know that we could probably do 5 or 6 more of these, but to start here, I think is a good spot, and then our goal is to just keep progressing these two, and especially with this topic. And so
I just think it's hard to do it tastefully, and that's what they do a good job of. You know, like within chiropractic, there's so much weirdness in this space. So when and I mean, don't get me wrong, you guys are weird, but
Absolutely.
But I mean, I think to have like the evidence-based group, if you will, or evidence-informed, whatever the new term is, like in this space is really important, and that's the void they're filling.
Absolutely.
Yeah.
So no scare tactics, no garbage like that. It's just good information and stuff you can apply. So
Thank you. Yeah.
let's get you guys on the road. We'll finish our Sputniks, and we'll see you guys soon. All right. Good luck with patients.
Take care.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.